My dear friends, colleagues, ladies and gentlemen, good morning. Welcome to this Sunday Echocardiography breakfast session. It's a distinct pleasure for me to invite you for this webinar. Today we'll be dealing with lung ultrasound at the part 2. Part 1 was done two weeks ago. Dr. Chacko will be deliberating the talk, and we are grateful to him for joining us. Dr. Sunil Karanth and Dr. Arjun Alva will be with us to lead us through the talk. Before I hand over the mic to Sunil, I would like to mention a few housekeeping points. Kindly keep all your mics muted. Excepting for the speaker and the moderator, all the mics must be muted. Kindly keep your mics muted. Question and answers will be done at the end of the talk in about half an hour's time from now. And keep your videos also off during the time of the talk, excepting for the speaker and the moderator. And without much ado, I'll request Dr. Sunil Karanth, who is a leading intensivist in Bangalore, to take over and carry on with this session. Thank you so much.
Thank you, Dr. Mudlidhar, sir. Thank you for that wonderful introduction. So, lung ultrasound, as we all are aware, has come a long way in the last 10 to 15 years, or probably even a little more. It's become an integral part of our monitoring armamentarium in the ICU. There was a time when we studied, when I was training in internal medicine, it was said that ultrasound is not a good modality of investigation for lung. But over the last 2 decades, we know that its role, especially in pathological situations, is significant in terms of very early diagnosis, high sensitivity, constant monitoring of how the lung has response in a situation of any kind of systemic disease and such other sort of things. So Dr. Jose, my teacher, has been one of the first proponents of lung ultrasound and POCUS itself in ICU, and I have a lot of things that I owe to him in my ICU training, and also particularly in the skill of ultrasound. So without wasting much time, as we all know, Dr. Jose is one of our senior intensive care teachers for the last two and a half plus decades, and is a leading figure in most of our academic conferences, academic teaching sessions, etc. So it will be my pleasure to introduce Dr. Jose to continue with the second part and to do more learning for myself and for the entire set of doctors who have joined here. Dr. Jose, I request you to start the session, and we'll get the questions at the end. Thank you very much, sir.
Thanks. Thanks, Sunil. Thanks, Molly. So I'll just start sharing my screen. Just a moment. Is my PowerPoint on the screen now?
Yeah, I can see the screen. Thank you.
Is the first slide visible?
Yes, it's visible.
Okay. Okay, so I'm just carrying on with where I left last time. We covered part 1, which was just a very basic. So we move on to part 2 today. So last time we saw how do you look at the lung, the very basic images that you get. And we also looked at how do you grade the severity of lung involvement based on the ultrasonographic picture. So if you look at the right bottom screen, which is a normal lung, you see the pleural line. There are no B lines there, but if you look at image number 1, you can see discrete B lines, which is an early stage of lung involvement with interstitial fluid. That image shows coalescent B lines. And then finally, there are several features of consolidation, including hepatized lung, air bronchograms, Schett sign, and so on, which we went through in detail last time. And most important, one of the most important methods in which to follow up the involvement in the lung and as to how it is progressing over time is to assign a score to each of these 6 zones in each hemithorax from 0 to 3. So you have a total of 36 points for both hemithoraces put together. So that's how you score the lung, and you assess the progress of the lung involvement by ultrasonography by the aeration score. And one of the key images that we saw last time, which I would just like to reinforce yet another time, is the lung point sign that you get in pneumothorax, which can come in very handy, particularly when you need a quick diagnosis by the bedside and you need to stick in a tube if it's tamponade. You can't wait for the radiographer to walk in. So the lung point is when you see the pleura sliding on half of the screen, the pleura doesn't slide on the other half, and you see the junction between the collapsed and the moving lung, which is the telltale sign of a pneumothorax. Okay, so when we finished last time, somebody asked the question as to how do you measure the volume of pleural effusion? As you can see on the screen, that's a typical pleural effusion. My probe is on the right hypochondrial area. You can see the liver, you can see the diaphragm, and you see the lung floating in fluid like a jellyfish. It's called the jellyfish sign, wherein the lung floats in a lot of effusion. You can just eyeballing the pleural cavity, you can say that there is indeed a lot of fluid. But how do you measure it was the question. There are several methods of measurement. Of course, there is no single precise measurement. Eyeballing by an experienced observer is probably as good as any kind of precise measurement. But if you really need to measure it objectively, the way to go is to look at the maximal separation between the collapsed lung and the diaphragm, as you can see here in millimeters. So that distance, which is a maximal diameter in millimeters, and then multiply that by 20. So 20 times the maximal separation in millimeters will give you the volume of pleural effusion in ml. So if this distance is say 30 millimeters, you multiply 20 by 30, you get 600 mils. So there is 600 mils of pleural effusion in that case. So that's how you look at the volume of pleural effusion. As I mentioned, there is no precise measurement. Just eyeballing will give you a very rough estimate of the volume of fluid. And if it is big enough, if you feel that it requires drainage, the patient is symptomatic, and if you can help the patient by draining it, again, ultrasound will come in very handy. The way to do it is, the way I do it, is to use the microconvex probe, place it just above the costal margin, look at the effusion very clearly. You can see that there is a huge collection there, and then direct the needle under guidance. You can see the needle come through. It's just about to hit the chest wall, gone through, and then the next step is to wire it. And once you wire it, I feel it is extremely important to make sure that the wire is in the right place. And how do you do that? Your most important concern is the wire should be above the diaphragm. It should not be below the diaphragm. You can obviously do a lot of damage if you pass your wire below the diaphragm and hit the liver or the spleen. So here you can see the wire going through. It is floating in the fluid, you think, but then the key is to figure out where the diaphragm is. And there you can see the diaphragm just about appearing. The head is here. This is the feet end. That's the head end. So that's the diaphragm, and you can see the wire is well above the diaphragm, and it is safe. And I will just play it again. Here it's even more clear. You can see the diaphragm. That's the chest wall, and you can see the wire going through. So that means the wire is in the right place. So before you indulge in your huge, monstrous dilators, it is good that you make sure that the wire is in the right place. If you feel the wire is below the diaphragm, then maybe you can just pull out without causing too much damage. So that's how you do an ultrasound guided drainage of pleural effusion. There are many patients in whom you see that they are hypoxic. 90% of the time, the ultrasound will be able to tell you as to what is causing the hypoxia. There are several very clear-cut signs. In fact, there are very few patients in whom you cannot identify the cause of the hypoxia. That's one of the very strong points of using bedside ultrasound. But then there may be an occasional patient whom you find the lung looks normal everywhere. You cannot see what is the problem. There is no pulmonary edema. There is no ARDS. There is no consolidation. There is no pneumothorax. There is no nothing. You don't know what's going on. And if that is so, there are a few possibilities which can escape from the ultrasonographic view, which can elude the diagnosis. And one of those, of course, is acute pulmonary embolism. So in your patient who is severely hypoxic, maybe hypotensive, you see normal lungs, then you pull out your echocardiography probe and look at the heart. And if you see an image like this, and if the clinical situation suggests that pulmonary embolism is possible, like a patient with a malignancy or an immobilized limb because of a fracture, and if you see hypoxia and this kind of image with right heart dilatation, then obviously the diagnosis is very clear-cut. Even if you don't do a CT scan, you can tell very clearly that there is indeed acute pulmonary embolism. And you can even see the apical sparing RV dysfunction in this case. So if you don't find a reason on your ultrasonography as to why is your patient hypoxic, go for the echo probe, look at the heart, see if there is any right heart dilatation that will suggest pulmonary embolism. So we'll pass on to how do you troubleshoot a patient who is on ventilator. And one of the most crucial points during ICU stay of a sick patient who's been on mechanical ventilation for a very long time is the weaning phase. And that's a very crucial phase wherein you need to focus and give dedicated attention by the bedside at each stage of the weaning process. Of course, if it's a straightforward postoperative case, there is no weaning, you just pull out the tube. But unfortunately, many of our ICU patients are not like that. They experience several hiccups along the way, and that's when ultrasonography may be of immense help by the bedside. And there are three key functions that you look at with your ultrasonography during the weaning process. You look at the lung to see if it is holding on. Does the heart fail with your weaning effort? Will the diaphragm hold on? So these are the three crucial functions that you can easily assess by the bedside. You look at how the lung progresses. You look for any cardiac dysfunction, particularly diastolic dysfunction, and you look at the diaphragm to see if it is contracting adequately or not. So let's take these one by one. First of all, the lung. We've been through the lung in detail previously, so the most important thing that you look at in the lung is the appearance or worsening of B lines during the weaning process. So suppose you start like this, and if you see your patient is becoming tachypnic, if your patient is using accessory muscles, and you see B lines, then of course you back off, put them back on support, maybe use some diuretics, anti-failure medication, and take it forward from there. Or if you see part of the lung collapsing down, then again, you back out and continue with full support for the time being. And during the process of weaning, you can use the aeration score that I mentioned and objectively look at by how much the score is going up or down or staying the same. And that will give you a good idea about where are you going in terms of weaning your patient. Second most important is to look at the heart function, particularly the diastolic function. Most patients who are on ventilation, particularly the relatively younger patients without too many comorbidities, they do not have systolic dysfunction, but many of them may be on the verge of diastolic failure, and that may be precipitated by a premature weaning process. So just going through the basics, I'm sure you would have probably gone through this several times previously in your echocardiography classes, but just to briefly summarize, normally during the diastolic phase, the diastolic filling occurs in two phases. There is the early phase wherein the ventricle relaxes, the left ventricle relaxes, a pressure gradient exists between the left atrium and the left ventricle, and blood flows in. So that is when just relaxation of the LV results in a pressure gradient across the mitral valve, and blood flows from the left atrium to the left ventricle without there being any active LV contraction. So that is the first phase, or the E phase. And then the second phase is when the atrium contracts, and that results in another wave of flow across the mitral valve. So diastolic flow occurs in two phases. If you place your echocardiography probe, and if you place the cursor at the mitral inflow, just distal to the mitral valve in the LV, you will see these two phases of flow very clearly. So that's the first phase, which is a passive flow when the ventricle relaxes, which is E. And this is the active phase wherein the atrium contracts and blood flow happens. So you have E and A. And as you can see very clearly, this is a normal patient in terms of diastolic function. You see the E is more than A, or the early phase of filling by passive ventricular relaxation is more than the active phase during active atrial contraction. So E more than A is normal. But what's happening in this patient? This patient, during the course of weaning, you see that the A is looking like it is taller than the E wave. What does that suggest? It suggests that ventricular relaxation is not adequate and the ventricle is dependent on the atrial contraction. That's why A is more than E. So that's grade 1 diastolic dysfunction. That's grade 1 diastolic dysfunction wherein E is more than, this is a normal E more than A, and that's grade 1 where A is more than E. Grade 2 dysfunction, if you see in your patient who is 60 plus, 70 plus, hypertensive, diabetic, lot of other comorbidities, and if you see what looks like a normal diastolic function, if you see E more than A in a patient with several problems, including hypertension, diabetes, lung disease, age of 60, 70 plus, then you assume that this picture is not normal. You call it pseudo-normal. So E more than A in a patient with several problems. And one of the things to look at is systolic function. If there is systolic dysfunction, there will always be diastolic dysfunction, 100% of the time. So if you see normal E by A or normal or taller E compared to A in a patient with systolic dysfunction, it is not normal. It is pseudo-normal or grade 2 dysfunction. So that's grade 2 dysfunction. Of course, I'm not going into details. If you have tissue Doppler imaging, you can assess this much more precisely than through conventional echocardiography. So that's grade 2. And then finally, if you see the E is so tall that it is more than 2 times taller than the A wave. Remember, normally E is taller than A, but it's not more than 2 times A. But here you can see it's almost like 3-4 times as much as the A wave. And if you see that, that means grade 3 to grade 4 diastolic dysfunction. So using this technique of using pulse wave Doppler at the mitral inflow, you can assess the diastolic dysfunction during the course of weaning in your patient. Then, of course, third and most important is to look at the diaphragm. The most important muscle in the body is what I would call it. If your diaphragm fails, you are pretty much dead. So in a patient who is weaning off from ventilation, you look at the diaphragm very closely, even before you start weaning them off, especially in patients who have been on ventilation for a long time, on neuromuscular blockers for a very long time. All these patients are very much prone to get diaphragm dysfunction. In fact, during the COVID pandemic, we had several young patients who were on neuromuscular blockers for days together, weeks together. And finally, when their lungs improved, they just wouldn't come off the ventilator. And then when we looked at their diaphragms, we found that their diaphragms were in a very poor shape. So how do you look at it? There are 2 things which you need to look at. The first is diaphragmatic excursion. Diaphragm excursion is simply the movement of the diaphragm down as it contracts. So during inspiration, the diaphragm contracts and it moves down and the lungs get filled with air. That's what you see here. And how do you look at this movement? You need to measure the distance through which the diaphragm moves during inspiration, and this distance constitutes the diaphragmatic excursion. And to do this, you use a low frequency probe. You can use the echocardiography probe or the curvilinear 5 megahertz probe. Either of these is good. I personally prefer the echocardiography probe in our machine, which seems to do a very good job. That's with the GE machine. But there are other machines in which the curvilinear probe may be better. So it depends on the kind of visualization you get from your machine. So you hold the probe, place the probe in the mid-clavicular or anterior axillary line, the probe marker to the right of the patient. And if you do that, you get this image. And then the next step is the most important step. Switch to M mode and look at the distance through which the diaphragm moves. So here you can see the diaphragm has moved from here to here, and a reasonable cutoff is 20 millimeters or 2 centimeters. So that's the bare minimum. If your diaphragm has an excursion of more than 20 millimeters or 2 centimeters, it means your patient may be okay in terms of diaphragmatic function. Of course, you need to assess this repeatedly during the course of weaning. So much about diaphragmatic excursion. The second key measurement, here again, you see diaphragmatic excursion. In this patient, you hardly see any excursion. You don't need to measure anything here. You can see the diaphragm very clearly, and there is hardly any movement discernible with inspiration. So if that happens, you don't need to really measure. You can tell just by eyeballing that's very poor diaphragm function. The second component of diaphragmatic assessment is to look at the diaphragmatic thickening. So when the diaphragm contracts, it contracts and it thickens as it contracts. If you look at this image, so that's the diaphragm. Here, I'm placing the probe. You need to use a high frequency linear probe to get a close resolution of the diaphragm. And you place it in the anterior or mid-axillary line, usually the mid-axillary line or even slightly posterior. Probe marker should point to the head of the patient. So you see skin, subcutaneous tissue, and then finally you see two parallel lines, one above the other, and below that you see the liver. That's the liver, and just above the liver you have these two parallel lines. This is the peritoneal layer, that is the pleural layer, and you have the diaphragmatic muscle in between. So let us click on the image and you see that the diaphragm, as it contracts, it starts from here, and as the patient breathes up, you keep your eye on the diaphragm, it will thicken, 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 and it reaches this level. So that is the way in which the diaphragm contracts and thickens. So that's what you try to measure objectively and see if the thickening is actually okay. If your diaphragm, the patient's diaphragm is contracting optimally or not. So here I'm actually demonstrating on myself, looking at my diaphragm. I'm taking a deep breath in, and here again, let's start from the baseline. So that's the baseline thickness of the diaphragm. When I take a deep breath, as you can see, it thickens, 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 and it reaches a maximal thickness there. So that's the maximal thickness. This is the minimum thickness. So you have the maximal and the minimum thickness. So all you need to do to calculate the thickening fraction is a very simple formula, which is the end inspiratory thickness, which is the maximum thickness, minus the end expiratory thickness, which is the minimum thickness. So maximum minus minimum divided by the minimum, which is the end expiratory thickness, multiplied by 100. So you just express the thickening as a fraction of increase from the baseline. And here again, if you have a thickening fraction of more than 20%, there have been several studies which have looked at how much is optimal. 20 to 30% is what people have seen, but the bare minimum again is 20% thickening. So it's reasonably easy to remember. Excursion more than 20 millimeters, thickening more than 20%. If your patient has these two features, then you can rest assured that the diaphragm may be functioning okay. So do remember, diaphragmatic function assessment is a key parameter to monitor by bedside ultrasonography when you're weaning your patient. This patient has not normal diaphragmatic thickening, but it is thickening nevertheless. If you measure it, it'll probably more than 20%. But look at this particular patient, one of our COVID patients, a young man was stuck on the ventilator for weeks together. He is inspiring or trying to do so, but then you can hardly make out any thickening at all. So he is bound to fail. It is going to take time. We are all into looking at what is an optimal PEEP level, particularly when you're taking care of patients with ARDS. ARDS, as you know, is a very heterogeneous disease which results in very asymmetric involvement of the lung. It's basically a dependent lung disease with consolidations much more prominent in the dependent areas, while the non-dependent areas are less involved, like the apices of the lung may be relatively free. The so-called baby lung concept is based on this particular observation that some of the lung may be thickly consolidated, collapsed, and some of the lung may be very much open and may be ventilatable. And the extent of the ventilatable lung or the baby lung will vary depending on the severity of the ARDS. So all your efforts in a hypoxic patient will be focused on trying to open up those areas of the lung which are potentially recruitable Of course, there will be parts of the lung which are rock solid, which you can't do anything about. But the big question is, will you be able to recruit at least some areas of the lung by incremental levels of PEEP? And if you do so, it'll obviously improve the oxygenation. And that is the first step towards supporting your patient. So how do you use ultrasonography to assess recruitability, to assess if increasing levels of PEEP will indeed result in opening up of the collapsed consolidated lung? This patient we had a few weeks ago, he suffered severe traumatic brain injury, severe chest trauma, and then predictably by day 10 or so, he developed severe ARDS. And when you looked at the lung with ultrasonography, this is what we found. The lung looks like the liver. It is a hepatized lung. Lot of white streaks, which are the air bronchograms, looking like shredded paper or the shred sign. And as you can see, there is hardly any air movement. So at this stage, this patient was actually on 100% FiO2. He was saturating about 80 to 85%. And we were about to prone him, but because he had a spine fracture as well, we were extremely reluctant to do so. So that's when we looked at the lung and saw this. And then from 5 to 10, as we increased the PEEP, we could see a lot more air coming through, a lot more white in the hepatized lung, as you can see here compared to this image. Part of the lung is still, of course, hepatized. It is still consolidated. So then we spent about 5 minutes with this level of PEEP and then stepped up the PEEP further, encouraged by what we saw. And then you could see that the lung was expanding much better. In fact, most of the lung was expanded. There are, of course, a lot of B lines, coalescent B lines, but that's better than a solid lung like this. And here again, some of the lung is still hepatized, as you can see there on that particular image. So as we increase 5 to 10 to 15, for 5 to 10 minutes at each level, there was progressively more aeration. But finally, at 20 of P, the lung appeared almost like completely expanded, except for coalescent B lines, of course. You can see the pleural line, and you can see almost discrete B lines there. So that is the final image that we got from as we stepped up the P from 5 to 10 to 15 to 20. All this happened within a matter of about half an hour. And during this period, the saturation increased slowly, and the FiO2 from 100% came down to 40% at this stage within half an hour. Now, this, of course, is not an isolated case. We've been doing this over the last several months, and in many patients, we find that the lung may be recruitable. And of course, as I mentioned, if you find the lung is not recruitable by ultrasound, if by stepping up the PEEP, you don't find increased aeration, then of course, there is no point in increasing the PEEP. It'll only cause harm. It won't give any benefit to your patient. Of course, the ARTSNet table suggests PEEP based on their FiO2, but it's just a ballpark number. And they suggest a PEEP of 22 to 24 centimeters of water for 100%, but that would really be valid only if the lung is recruitable. And recruitability is highly variable depending on the extent of involvement in ARDS. So instead of just blindly going by their FiO2, it is very useful to look at the recruitability using ultrasound at the bedside. So just to summarize, ultrasonography helps you to diagnose pulmonary edema, consolidation, pneumothorax, collapse, pulmonary embolism, if you don't have any lung findings, but there is right heart dilatation. Pulmonary edema, the picture is very clear-cut. Lot of B lines, discrete or coalescent, and it is spread symmetrically across both the lungs in cardiogenic pulmonary edema. In ARDS, it'll be patchy. APCs will be relatively free. The dependent areas will be more affected. Consolidation, there are many different signs. You get subpleural consolidations, you get dynamic air bronchograms, you have hepatization, shred sign, and so on. So that these are the features of consolidation. And in many patients, you may just see subpleural consolidations as you see here, especially in viral pneumonias. In fact, we encountered this phenomenon in most of our patients with COVID. Pneumothorax, we know that pleural slide will be absent, and the specific sign is to look for the lung point. Collapsed lung is wherein you see hepatized lung, tissue-like lung. There are air bronchograms, but the air bronchograms are static, unlike in consolidation, where the air bronchograms are dynamic. And pulmonary embolism, when your patient is hypoxic, you can't find anything abnormal in the lung, but you see right heart dilatation. And as I mentioned last time, in your patient who remains persistently hypoxic in spite of increasing levels of P, do look for a right to left shunt through the opening up of a foramen oval. And if you do the bubble test, you will see this picture. It is not uncommon. You will see patients who are severely hypoxic with high levels of PEEP getting this problem of opening up of the foramen oval with right to left mixing. And if that happens, your line of management becomes entirely different because you need to cut back on the pressures, not increase the pressures. That's how crucial it is. And as I mentioned to you last time, our book on controversies in critical care just about to be released. And for those interested, please look at this book. There are many hot topics, burning topics, which you often encounter by the patient's bedside, to which you can find ready answers here. Thank you.
That was a lovely talk. Absolutely wonderful talk. Dr. Sunil is available. Can you take up the questions and address them? Is Sunil there? If he's not there, I will just go through the chat box. Is there a formula to estimate the effusion in pediatric patients? Do you have any formula for pediatric patients?
I think the same formula should hold, although I have no experience with kids and I haven't read anything to that extent. But I think if you look at the numbers and look at the measurements, it'll probably hold true for children as well, although I'm not sure. I haven't actually looked at the literature.
Sure. Thank you. And there are comments that it was a wonderful session. And where do you keep the cursor when tracing the M mode for diaphragmatic excursion?
Yes, just
where do you
a
keep the
moment.
cursor when
Yes,
you trace
I saw that
the M mode?
question. You need to keep the cursor. I hope my screen is still visible.
Yes, yes, it's visible.
Yes, so.
Can you hear me, sir?
Yes, yes, we
I
can.
Yeah, I think it was, yeah.
So
I can't see any questions on the chat box. That
there are a couple of them. I've just finished one question.
Sure.
Second one is the way to keep the cursors when tracing M mode for diaphragmatic excursion.
Yes. So this particular slide shows very clearly. So you place your probe in the just above the costal margin in the mid-axillary or slightly posterior, mid-axillary line or slightly posterior. And when you do that, this is the head end and that's the feet end. You see the diaphragm like this. That's the curvature of the diaphragm. And then you need to place your M mode cursor vertical to the diaphragm. It should be perpendicular to the diaphragm. It should not be at an angle, because if you place it at an angle, obviously the measurement will be wrong. So you get the curvature here, place the cursor vertically at right angles as much as possible, and then switch to M mode. Then you see the excursion like that. More than 20 is good. Less than 20, you need to perhaps go back on ventilator support. I hope that's clear.
Yes.
There is one more question. How to calculate pleural effusion in the presence of loculations?
I don't think there is any
Yeah.
reliable method by which you can calculate the volume if it is loculated. Of course, each locule will have its own volume. Not much meaning in doing that as well, I think, because if you have a real loculated effusion, you won't go by ultrasound and drain it. You will obviously have to do CT scan and look at where the locules are and then direct your drainage through percutaneous or open methods as appropriate.
And also, many times, if it is loculated, drainage itself may be very difficult to do. We may have to end up either doing a VATS or some sort of a deloculating procedure like thoracotomy or something. Decortication. Yeah. The next question is, what is the reason for poor diaphragmatic excursion? Is it reversible?
The most common cause of diaphragmatic dysfunction in the ICU is the neuromuscular weakness that you get in patients on long-term mechanical ventilation, or sometimes even shorter-term mechanical ventilation. And the causes for neuromuscular weakness can be several, just out of muscle atrophy over time, disuse atrophy over time as you keep ventilating them for days together, weeks together. Then, of course, the use of neuromuscular blocking agents has been incriminated in diaphragmatic dysfunction, although some of the recent studies have not actually really been able to confirm this suspicion. But you have obviously seen in many patients, there's a lot of experience as well. Patients who require neuromuscular blocking agents for a long period of time do in fact become very weak, and their diaphragms become very weak, and they take a very long time to recover. And third, of course, is neurological conditions like myasthenia, Guillain-Barré syndrome, or unilateral diaphragmatic palsy because of phrenic nerve palsy, particularly post cardiac surgery. So these are situations in which you specifically look at the diaphragm dysfunction. But of course, it's most important in patients who are weaning. And will it recover? Of course, many of these patients, if their lung condition improves, and if they are otherwise okay without sepsis, without involvement of other organs, if ventilation failure is the only problem, usually they improve over time. It's just a question of being patient and being slow and patient with the weaning process.
Next question is, how does a phrenic nerve injury during cardiac surgery look on diaphragmatic imaging?
The finding is no different to what you would normally find. The diaphragm will not move. There will be no excursion, no thickening if it's completely paralyzed. And there may be a reverse paradoxical movement, which may be appreciable, because normally during inspiration, the diaphragm moves down. But in phrenic nerve palsy, if you take a deep inspiration, the diaphragm might actually move in the opposite direction. It'll move up on the affected side. So that's a paradoxical movement, the so-called sniff test that you use to look at the paradoxical upward movement of the diaphragm when you draw in a deep inspiration.
Can I add to that, Dr. Jose?
Yeah, yes, please.
Okay. Yeah, so when you have this phrenic nerve palsy, you have to look at what is the context, especially if it is a post-CABG patient with Lima harvestation. The proximity of left internal mammary artery to the phrenic nerve proximally is one thing. And when there's a new operator, this can easily get damaged. So most of the time when you do a Lima harvestation, left phrenic nerve pulse is what we see. And it is not easy to detect it when the patient is on mechanical ventilation. So once the patient is extubated and you do a post-extubation X-ray, the left dome looks elevated. And this, again, as Jose mentioned, you can confirm it by using an ultrasound. The diaphragm will not be moving on the left side, whereas right side, it will be having a normal movement. So there's a differential movement on the ultrasound. That's how you diagnose. And of course, sniff test can add to the value. Fluoroscopy was done previously. That is not done off late now.
Yeah, it's not required. Ultrasound is equally, if not more effective in diagnosing it. And what I also feel is that in most of these patients, although they have unilateral paralysis, they are not clinically affected. This may be just an accidental observation. Many of them are asymptomatic in spite of unilateral paralysis, I feel.
Yeah, Most of the adult patients, as Josh mentioned, tolerate it quite okay. What we do is we just try to put them on non-invasive ventilation post-extubation during their hospital stay. And that really helps. And in the pediatric population, it is a little different. Even a unilateral phrenic nerve palsy can cause a lot of problem. And you may have to use diaphragmatic plication to tide over this crisis and get them out.
Okay.
Yeah.
Thanks for that.
Thank you.
Yet another question. Threshold for tracheostomy based on diaphragmatic ultrasound. Please brief.
Well, the decision to do a tracheostomy is not entirely based on diaphragm function. It depends on so many other things, like, how long do you think your patient is likely to require ventilator support? And this question may not be easily answerable. So initially, you would go by the overall clinical picture. How well is the lung improving? How well are the other organs coping? What is the entire trajectory of illness? And based on that, you make a considered decision. And of course, if you see there is severe diaphragm dysfunction after a week or 10 days of ventilation, and if you see the trajectory of illness is otherwise not favorable, then you would strongly consider doing a tracheostomy at this stage. But certainly not in the first few days. You wouldn't go entirely by what you see on ultrasonography and the diaphragm function. Particularly, there may be some residual effect of neuromuscular blocking agents, and you may not be able to assess the diaphragm function to a precise level at this point. So you need to look at the overall picture, the way the lung progresses, the duration of ventilation overall, expected duration, look at the other organs. How is the patient progressing overall? Is he improving or static or worsening? So based on all this, you make a considered decision. It's just not based on a single parameter.
So it's more of a clinical context that to take a call. So tracheostomy itself is based more on a clinical context rather than on ultrasound.
Yes.
One more question. Diaphragmatic values for weaning from ventilation, is it the same for adults and pediatrics?
Pediatrics, I'm not able to tell you. I haven't checked the literature on that. I would think the numbers will be, of course, very different compared to the adult numbers that I cited. I don't know what extent this has been studied either. It is mainly, and it's something relatively new. It is not something which has been going on for a long time. So whatever numbers we have is largely for adults. And you need to really look at the literature to see if there is any relevant literature in this regard. I don't take care of children, so I'm not sure.
Our pediatric DNB training, they were doing some study like this.
Okay.
I will check with them and get back to you if they found something significant. I just
Yes.
want to ask you one question. That is, when the peak was increased from 5 to 10 to 15 to 20 with improvement in the lung aeration,
Yes.
was there an improvement in the lung compliance? And did you also concurrently check right to left shunting at the atrial septal level? Because as we increase the PEEP, RV pressure is likely to increase with corresponding increase in the RA pressure, and any PFO might get opened with increased RA pressure.
Yes, you're very right. If you increase the PEEP, go too far with your PEEP level, obviously there is a possibility that the foramen ovale may open up and the right left shunt may happen. In this case, we did look at the compliance because they're obvious on the screen itself. The compliance did not change very much from 5 to 20. It didn't really change very much. I didn't specifically look for right to left shunting in this case because there was, as I mentioned, an obvious, very, very dramatic improvement in the oxygenation, starting from 100% FiO2 at a level of 5 of PEEP, which we were able to cut down to 40% at 20. And the PO2 also rose significantly during this period. So that was a clear indication that the lung was getting recruited. And of course, if we had observed hypoxia or worsening hypoxia with incremental levels of PEEP, we would have strongly suspected a shunt. So the compliance, as you increase the PEEP, and even if the lung gets recruited, the compliance may not actually increase. It might remain the same, or it might even decrease a little bit. But what really matters would be the delta P, or the driving pressure, which is P plat minus PEEP.
Yeah.
And the whole point is to try to keep the delta P, or the driving pressure, P plat minus PEEP, at 15 or less. If you manage to do that, then that's good enough, because delta P is purely tidal volume titrated to compliance, assuming that a constant tidal volume of 6 mils per kilogram will not be appropriate for all, because this tidal volume depends on how much lung is involved and how much lung is not involved. This is highly variable in ARDS. So it doesn't make sense, although of course ARDS studies suggest that a fixed tidal volume based on the body weight doesn't seem rational. And that's exactly why Mato and colleagues looked at this particular parameter of delta P, and they found a strong correlation between delta P and mortality rather than tidal volume and mortality. So P increase, and if the delta P is below 15, my own personal feeling is that's okay, I will take that.
No, thank you for the response, Jose. I also want to mention or reiterate what you said about diastolic function. Actually, in several cases in the past, about 20 years ago, surgeon would ask us, the EF is 40–50%, EF is good, why you're not able to extubate this patient? They would ask us. At least some of those patients had diastolic dysfunction, so the patient's chest was clear when on ventilator, and the EF was good. But as soon as you put them on spontaneous breathing, they would become wet and become tachypneic, may start sweating. So we were not able to extubate those patients, and we did not know what was happening. So some of those patients were obviously had diastolic dysfunction. It was manifest when we gave the heart the additional burden of breathing.
Totally agree with that.
The diastolic function as a parameter to be considered in ventilation.
Yeah, particularly in post-cardiac surgical patients, they have borderline LV systolic function. They can very easily slip on to severe diastolic dysfunction, which unless you check, you will not figure out.
Right.
One question is, how do you differentiate infected consolidation from non-infected consolidation?
I don't think ultrasound will be able to differentiate infection from non-infectious causes. You can't really do that.
Yeah, I think the only thing, as Sir mentioned, was differentiating pulmonary edema of cardiogenic versus non-cardiogenic, which you had elicited to during your talk regarding the asymmetricity of the ARDS.
Yes.
Next question is, will the same high PEEP be maintained after ensuring that the PEEP helped in the aeration of the lung? If so, how long we can maintain the same PEEP?
That's a very, very good question, which sort of confused me as well, because we obviously found that in this particular case and several other cases as well, as you increase the PEEP, the lung seems to get recruited dramatically on ultrasound and oxygenation improves. But then how long do you maintain this 20 of PEEP for? It may not be entirely safe to do so, particularly if the driving pressure is more than 15. So what we generally tend to do is keep the 20 or 15 for a period of a couple of hours or so, and then slowly cut back and see and go by the saturation and look at the lung again through ultrasound and see if there is any de-recruitment. So you can do serial ultrasound, and that's one method. And the second question, which I didn't discuss, is even if you see recruitment on ultrasonography, it could also mean that your normal lung is getting hyperinflated, which you will not know, which you cannot see with ultrasonography. The normal lung, particularly the epiphysis, may get overinflated, and that will be missed. And that might actually cause severe injury to the normal areas of the lung. So to prevent that from happening, there is another parameter not to do with ultrasound, another parameter that you can go by called recruitment to inflation ratio, wherein you drop the PEEP from a high level, 15 to 5 for a brief period, and look at the recruited lung volume between a high and a low level, say 15 and 5. And from that, you can derive, using a formula, what is the recruitment to inflation ratio. And that can tell you if you're actually recruiting the lung or you're just causing overinflation. So a combination of these two might be extremely useful. It's still in the early phase of study. Laurent Brochat and his group at Toronto are doing this. In fact, we are also planning a study based on these lines. I think it can be extremely useful if you use a combination of these two to look at whether you are recruiting or you're overinflating as well.
One more last question. In a patient with collapse and consolidation, how to differentiate between the areas of these lesions? How to look at these lesions for progress?
Collapse, as I described to you, is when you see a tissue-like appearance in the lung with this particular image. You see okay, in this particular image, you see tissue-like lung with air bronchograms. So, however, in collapse, of course, you see a tissue-like lung, but the air bronchograms will be static. It will not be mobile as you see here. And then, how do you know if it is progressing or not? For that, of course, you go by the aeration score that I mentioned, as you can see on this image. You divide the lung into 12 areas, 6 per hemithorax, and you score each segment of the lung as 0, which is normal, 1, well-separated B lines, 2, coalescent B lines, 3 for consolidation, and you look at the aeration of all the zones and come to a consolidated score. So that's an objective way of looking at whether the consolidation or the collapse is actually progressing or static, so or even recruiting. So if you go by the aeration score based on examination of all the 12 zones that I mentioned, you get a reasonable idea of how the lung is progressing over time. I hope that answers the question.
Yes, Dr. Jose. One more question, sir. Does lung recruiting cause additional damage in ARDS?
That is a general kind of question.
Yeah.
When you do recruitment, what you try to do is to open up the lung and prevent cyclical opening and collapsing with the increased levels of PEEP. So the whole point is to try to reduce the recruitment, de-recruitment, inflation, collapse sequence, and reduce the trauma, particularly between segments of the lung which are collapsed down and those segments which are inflated. So you try to reduce that, make the lung more uniform. That's the whole point. And of course, if you go too far, you might end up overinflating, and that might actually be harmful. So the whole point is directed towards how to accurately measure whether the patient is recruitable, first of all, and what is optimal recruitment. And of course, ultrasound is a very easy tool by the bedside to do this. And you could also use the recruitment inflation ratio that I mentioned to look at whether you're overinflating or if it's just right.
I think there are no more questions on the chat box.
Thank you for joining us, Sunil, Karanth, and Dr. Jose Chacko. I think there's a comment on phrenic nerve injury which can happen when the pericardium is incised, especially during close to valvotomy. Thank you for that comment. And because we are close to our time limits, so we will thank both Jose Chacko and Sunil Karanth for joining. And thank you everyone for participation and a wonderful participation. Thank you for that excellent lecture, Dr. Jose Chacko. Thank you so much. We'll see you again next Sunday, same time around 9 a.m. Please join by 8:45 so that we can start in time on 23rd April. Thank you so much and have a good Sunday.
Thanks, Murali. Thanks, Sunil. Thanks, everyone, for coming.
Thank you. Thank you.
Bye. Thanks.